Mike, you're up.
I was trying to find the unmute button. Most of the time, Bobby requests that I have the mute button on. This is one of the rare occasions when it's the other direction. So let's see if I can get this set up so it's an actual slideshow. All right. Hopefully there we go. Good morning, everybody. Hopefully I will finish this while it is still morning and we have not transitioned into afternoon. So for our last discussion of the year, I wanted to talk about crossover skill sets for integrated care, which relates very much to what we're doing, obviously. And so that was my original intent. And as I started putting this together, it morphed just a little bit. So the considerations for what I was thinking about with crossover skill sets that really we can all use, skill sets that will apply to all of us, that can cross over all of those dimensions, which is a pretty big ask. It's a pretty big task. So what's in consideration of that? So the first part is, what is integrated care? What are we talking about with skill sets for integrated care that we talk about very directly in this echo? And I thought that I had a good grasp of what I was thinking about with integrated care, and I suppose I did for what I was thinking about. But looking into it, I just wanted to put up a simple definition of this is integrated care, and I figured, well, SAMHSA will have something, or NIH will have something, somebody will have something. And the more I looked into it, the more I realized that it's much bigger than the simple concept that I had in mind. Because I was thinking about it really from a particular narrow focus. But depending on your focus, integration can mean a lot of different things. Are you thinking about it from, a state administration direction, from local public health, whether that's the health department or the Adams board? Are you thinking about it as a practicing clinician, or are you thinking about it from the role of being a client or a patient? So it can mean a lot of different things from a lot of different perspectives. There's a big focus on integration currently, and an increasing focus on that, really not just statewide or nationwide, but really worldwide. In a lot of the literature that I saw about integration, I thought this is going to be like, yeah, I'll look up the definition. It'll take 3 minutes and I'll have this slide put together. And a day later, some of the stuff that I have seen written about integration, the research that some of the meta-analyses have done, have identified over 175 separate different definitions of integration and integrated care. But to boil that down and simplify it, hopefully from our perspective, quite a bit of what's being investigated and directed about integrated care currently really comes from the perspective of, I pulled this from SAMHSA, and they have a center of excellence that they have developed, Center for Integrative Health Solutions. And they define it as the care that results from a practice team of primary care and behavioral health clinicians and other staff working with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. And really, that's the direction and the focus of a lot of integrated care perspectives right now, which really is the integration of behavioral health and primary care, and substance use is captured in that. So really, it's smaller than our perspective, and I'll get into that in just a second. The UK has had a task force working on defining integrated care for about a decade, at least in a dedicated fashion. And I really like the one that they're putting forth. I think it'll appeal to a lot on this. Their definition, their primary working definition of integrated care is from a patient perspective, from a client perspective. I can plan my care with people who work together to understand me and my carers, allow me control and bring together services to achieve the outcomes important to me. So I really like that. And I think it fits in with the perspective that we have quite a bit. The next part of consideration of crossover skill sets, things that would apply to all of the different dimensions of things that we do, is the MSY component of our ECHO, and that is the multi-system youth. And so that takes us into larger perspectives than thinking about just mental or behavioral health, substance use in primary care. So the MSY designation itself in Ohio refers to children and youth who are involved in multiple systems of CPS, mental health or addiction services, developmental disability services, and juvenile justice. And so to qualify with that designation, then you have to be involved in at least two of those. And we know, and you on this ECHO know, that as soon as a kid is involved in at least two of these systems, then the risks go up significantly. And one of those big risks is a risk for out-of-home placement. And sometimes that out-of-home placement can go into the custody of a public child service agency, a PCSA. And so the MSY approach is to divert that and keep kids in the custody of their families as much as possible. So a quick side track here. I'm going to pull out my soapbox and stand up on it for just a second, and then I'll put it away. But the designation MSY, I think it's a great designation for an airport, and it is. It's the Louis Armstrong International Airport in New Orleans. So MSY is great for that, just like CLE or CAK. But I think it's a lousy designation for a person, because it is need and system forward, not person forward. So we've kind of bantered that around, some ideas that we've come up with for a more person first designation. YMSI, youth with multi-system involvements, or YMS, youth involved in multiple systems. I kind of like YAMS because it rolls off the tongue. It's easy to remember. Youth accessing multiple systems. We could do a really long one, which would maybe be a little bit more descriptively comprehensive, CYFMSC, but that doesn't roll off the tongue. Children, youth, and families with multiple system connections. And in a nod to the amount of time that I spend alone in my little tiny home office, I came up with youth obtaining deeply entangled linkages, which I really liked because then we could have a yodel echo. But I'm not going to propose that one because I don't want to distract with flippancy. I mean, I will with us, because it's just us, right? But from a broader perspective, I don't want to be flip about it, because I am serious about this. And I'm not proposing that we change the name of the ECHO, because MSY is entrenched in the Ohio administrative code, but in conversation, and Dr. Beal already did it today. She didn't say MSY, she said youth with multiple involvements, multiple system involvements. And so I'm proposing that we stick to that. So integration for our youth with multiple system involvements is much bigger than the perspectives that a lot take. It's bigger than just 2 or 3 dimensions. The nice thing is now also part of our ECHO, because we are an SOC ECHO for youth with multiple system involvements. SOC is a long, well-established model for integrated care. It's been around since the mid-1980s. I talked about it a little bit in August, and really my intent in talking today was kind of an extension of what I talked about in August. And defined it then, and there's going to be a link to SOC resources if you would like to take a look at that and expand your knowledge on that. But even as well developed as the SOC model is, with these 10 overlapping dimensions of care and focus written into these, and it's not direct, it's not intentional, we could still add more dimensions that we are going to include intentionally, a nod, a recognition for developmental disability involvement. And I think it's written into most of these dimensions, and it's something that I've done in the past and decided to pull out very intentionally, a nod to trauma and nod to an acknowledgement trauma and developmental traumas, and how that is significant enough to have a separate dimension and a separate view. So thinking about our crossover skill sets, maybe it's a little bit bigger, because my in the picture here with with Dr. Beal, when she tasked me to do this, I thought I'm going to expand on what I talked about in August, which was thinking about really 2 or 3 dimensions that we talk about within our ECHO, which is the crossover of mental health services and substance use services. And really that then it just invariably also involves some of the other dimensions, especially trauma. But in talking to providers who deliver services on the mental health side and on the substance use side, there's a lot of anxiety and even angst and resistance about, well, I don't have the skills to do the other side. And so we've spent quite a bit of time talking about those crossover skill sets for mental health providers and substance use providers, and how much commonality there is in providing services to youth and to families. But as I moved into this, thinking about what we do in this ECHO, it's much bigger than just these 2 or 3 dimensions. So this is an example of one of the things that we have done and put out and talked about, thinking about that overlap of really just a couple of dimensions, where these crossover skill sets that are common to any provider on the mental health side, on the substance use side, and really we could say on the trauma informed side, with a view of the youth forward, the family guided, the cultural competent approach. Yeah, that's all recognized. But our perspective is just a little bit bigger than just those 2 dimensions. So maybe bigger than skill sets, because it's kind of a bait and switch on the title. I'm not even going to talk about crossover skill sets. A little bit bigger than that is maybe considering the core competencies that cross all of these different dimensions of care that we all represent and bring to the table with different perspectives. Nobody can have skill sets that cross all of those different dimensions. And that's the advantage of having a learning community like this. And really that then winds up being one of the major answers and responses to how can we increase our core competencies. It's being involved in a process like you have been involved with just by logging on today. So some core competencies, a little bit of the legwork has already been done. This is coming from that Center for Integrative Health, that Center of Excellence from SAMHSA. And again, this was thinking about behavioral health, substance use in primary care, but I think it's adaptable to what we do and how we think about things. They identified, I skipped over it pretty fast. They convened a work group. They polled key stakeholders and direct providers across all these different services. And then the project team itself narrowed it down to 96 core competencies. And we're not going to go through 96 core competencies, don't worry. But then, those 96 core competencies for providing integrated care were able to be categorized in 9 separate categories or dimensions. And so the 9 dimensions, and think about how these apply to the broader perspective of what we're doing here, how this applies to the services that all of us are providing and coordinating. So the 9 categories that they identified: interpersonal communication, having to do with rapport and communicating effectively. Collaboration and teamwork. That seems inherent to all of it, right? Effective interprofessional teams, and there's a lot written about interprofessional teams and integrated care. It's something I would encourage you to take a look at. Screening and assessment and abilities to do that, at least to screen. Everybody should have the ability to perform screenings. Not everybody should have the ability to do assessments because those are very specialized. But if you can do a screening and say, I think a deeper look here is warranted, then recognize and have the ability to refer for that deeper assessment. 4, care planning and coordination. 5, intervention and understanding the different dimensions. Not everybody has to apply those dimensions, but understanding them, being able to work within a plan with those. Cultural competence, certainly be relevant and adaptable to the families that we're serving. Systems-oriented practice, I'm going to talk about that just in a slide or two. Practice-based learning and quality improvement, and certainly being involved in this ECHO is a big part of that, right? Practice-based learning, we're taking practice, we're spreading our learning, and then we're taking that back to the folks that we serve, and that is a quality improvement approach. And informatics, using tech and support to improve integration. So these are the 9 categories that were identified to sort those 96 different core competencies. And I think that it's very adaptable to what we do here. And I think that it can really inform and direct. It would be great to convene a work group of our own and come up with our own very specific core competencies and see if we would adjust any of these headings. Of the core competencies, the categories identified, really standing out for me in terms of what we do. Number 1 is interpersonal communication. And this is our ability to establish rapport and effectively communicate with. And there's a big list after that with the youth, with the family, with the collateral partners in the family's life, and with other professionals. And then, is that most important with a question mark? For me, interpersonal communication is our ability to engage, and without engagement, you got nothing. And that's true not just with the families we serve, because that's how we think about engagement a lot, but can we engage with the collateral partners? Can we engage with the other systems that are involved? And can we find ways to get that effective communication so that we're all speaking a similar language that we understand? So that one I put forth from my perspective as being the most important. The ECHO model itself certainly fits in with quite a few of these categories. I'm not going to read all of this. There's going to be a link that you can do a little bit deeper dive exploration into the ECHO model itself if you're interested in that. But I really like the all teach, all learn that they promote on all of their self descriptions. So some resources that you can take a deeper look into this. And so this really was kind of a bait and switch, right? I don't think anybody came to this ECHO thinking, "Ooh, I want to learn about core skill sets and crossover skill sets." But so with the title of crossover skill sets, it really expanded beyond that. And so really that was the whole discussion in this didactic, right? It's just that there's room for a lot of exploration in this. And so some areas for exploration, if you're interested in it, are in this, and then this slide deck will be emailed out to you, so you'll be able to access these resources. There's the FCF website through Ohio, that's Family Children First, and then the FCFCs on the county basis, a link to ECHO. This is the Center of Excellence for Integrated Care established by SAMHSA. There's a link to that. There is Youth Associated with Multiple Systems. They might call it MSY, but we're going to call it probably Youth with Multiple System Involvement. YAMS probably sounds a little flip too. From that Center for Integrated Care, they have quite a few video resources that you can access, and then there's a link to those. The system of care approach, I had posted this previously for you folks, but just as a reminder, it's a great readable brief that really reviews the system of care from the developers themselves. If you are interested in the crossover skill sets themselves as they apply to 2 or 3 of the dimensions, really substance use, mental health, and trauma, we have a recorded, I think it's about 2.5 hours, maybe 2 hours, discussion that we did. It's on the TA Network YouTube website. And then wrapping up with some references from what I talked about, if you're interested in expanding any information about that. And with that, I am done.